It's been well known that checkpoint inhibitors have had a particularly impressive role in patients with solid cancers and also with Hodgkin lymphoma. And the hope was that checkpoint inhibitors might have a role in patients with acute myeloid leukemia. However, this has not been demonstrated to be the case so far with PD-1 or PD-L1 inhibitors. So this study was aimed at investigating the role of a different checkpoint target called TIM3 and its combination with hypomethylating agents, and to see if there was, first of all, tolerability with this combination, and secondly, efficacy in patients with high-risk MDS or acute myeloid leukemia. The study was designed to investigate, firstly, decitabine in combination with the TIM3 inhibitor MBG453. And the reason for targeting TIM3 is that it has a dual role potentially in patients with myeloid disease. Firstly, it's expressed on myeloid progenitor cells and not so much on normal progenitor cells. And secondly, it's a checkpoint on effector cells with the possibility that it would enhance the immune response against patients with MDS or AML. And so combination with decitabine was first embarked upon, and this was shown to be tolerable in combination with MBG, given at a schedule on either day 8 and day 22 or once a month. And at this stage, dose escalation is continuing with a dose of 800 milligrams of MBG453 every 4 weeks in combination with a standard schedule of decitabine. And this was investigated in patients with both high-risk MDS and AML. A parallel cohort was also investigated, which commenced after the initial decitabine exploration, and this time this was another hypomethylating agent as a cytidine in combination with MBG453 in the same schedules as I outlined for decitabine. These studies have been performed and preliminary results have been presented first at the American Society of Hematology in December last year and updated at this European Society of Hematology meeting. So with respect to higher risk MDS, the patients enrolled had particularly higher risk disease as represented by the revised IPSS score, and patients in the hypomethylating agent cohorts had very high risk MDS disease on the order of between 22% of patients. Furthermore, patients with AML who were also investigated also had particularly higher risk disease, with about 50% of patients having adverse cytogenetic risk according to the ELN classification. With respect to tolerability, it was found that MBG in combination with hypomethylating agents was on the whole tolerated similarly to patients receiving hypomethylating agents alone. With respect to immune-mediated adverse events, there were about a quarter of patients that had what could potentially be classified as immune-related pathology. However, it was very difficult to distinguish what was truly related to MBG453 and what problems were related to patients either having AML or receiving hypomethylating agents. However, in terms of higher grade immune-related pathology, the rate was very low and was only about 4% in the study. Therefore, the combination was well tolerated, and then maximum tolerated dose has not so far been identified, and the rate of immune-related pathology was generally low grade and generally ameliorated with either steroids or temporary drug cessation. With respect to response rates, the response rates for patients receiving decitabine are more mature in terms of the results because that cohort opened earlier, whereas the azacitidine cohort opened later, and so the results are still maturing in this group. What's notable, however, is that patients with newly diagnosed high-risk MDS, the response rate with respect to decitabine plus MBG453 was just over 60%, which I think is quite impressive, particularly as this was a very high-risk subgroup of patients. With respect to azacitidine in combination with MBG453, high response rates were also observed on the order of 57%. and hopefully these responses are likely to improve as the data in the azacitidine cohort improves or matures with time. With respect to patients with newly diagnosed AML, response rates with decitabine and MBG453 were almost 50%, and with azacitidine plus MBG453, approximately 30%. What was especially interesting in the MDS cohorts was that patients with very high-risk disease, as according to the revised IPSS score, seemed to have response rates which were at least numerically as high, if not higher, than patients with high-risk disease. And it'll be very interesting to see what happens when there are more patients enrolled onto these studies to see whether the possibility of a checkpoint inhibitor in combination with a hypomethylating agent might have preserved activity in these higher risk patients, as opposed to many other therapies where responses and outcomes are usually lower in patients with poorer risk disease. With respect to durability of response and tolerability over time, combination with hypomethylating agents and MBG453 was found to be very well tolerated over prolonged periods of time in patients receiving these treatments. Myelosuppression was not a major issue, and patients on average could receive at least 8 cycles of therapy if they were able to remain on study, with many patients receiving therapy for many months and still ongoing. So obviously data will continue to mature, but early signs are promising that this is a well-tolerated combination with good activity in patients with high-risk MDS and quite reasonable activity also in patients with newly diagnosed AML. So in conclusion, MBG453 is the first TIM3 inhibitor taken into patients with myeloid disease in combination with hypomethylating agents, and the results to date have led to the development of further randomized studies and expanded studies to try and delineate the role of these drugs in patients with high-risk MDS and AML further into the future.